We are starting the second session of today, and we are very pleased to welcome Dr. Stella Lee from Birkham and Women's Faulkner Hospital Otolaryngology Clinic. Hello, Dr. Stella.
Great, thank you so much. This is the first time I've heard what an osmonaut is, so it's very cool. I'm very excited to be here. I wanted to bring the patient perspective regarding smell loss and how it can impact quality of life, but also some of the projects that we've been working on to better understand how to measure smell. And hopefully, we think that as a rhinologist that this is really the next frontier in our field, an area where we need to make more rapid advances, especially because of some of the circumstances we live in. So this is an example of a patient of mine. We're looking, so as rhinologists, otolaryngologists, we use millimeter scopes to look inside the nose. I don't know, have any of you seen inside the nose before? Never. Okay, so, well, of course, my otolaryngology colleagues in the audience, but this is a patient who has severe nasal polyposis. And even before COVID, we were struggling with, patients who had significant loss of smell, difficulty breathing, because of chronic rhinosinusitis with nasal polyposis. And this is an inflammatory disease where we don't have a cure for it. It's almost like asthma of the paranasal sinuses. So you can imagine here just pointing out some of what the structures are. We're looking at the nasal septum on the left side of the screen. Those are the polyp growth. And as you can imagine, these patients who have this condition, which is about 4 to 8% of the U.S. population and up to 10% worldwide, can you imagine being you can't breathe, you can't taste, you can't smell, and you have trouble also with sleep, cognition, and we know that it's a significant disruption to quality of life. Just another picture just to demonstrate what a normal nose kind of looks like. So as a nose doctor, I see many noses of patients. And this is a patient, I was at Pittsburgh for 10 years before moving to Boston last year. So this is a patient of mine who worked at a coke factory. And also I have patients who are coal miners still, who are working the fracking industry. You can see all the black debris that's in the nose. And those are called turbinates. Those are structures that are very important in the nose to humidify, warm, filter the air. And also there's an immune function of the nose. So the nose is just not an aesthetic piece for our face. It plays a super important role in immune function, in also obviously in, smell and also flavor that we get from that, but also in immune function. And as we know, when there's disruptions of olfaction, and this, just pausing up there, you can see that's way up high is where the olfactory nerve fibers come down from the brain through the cribriform plate. And we know that the nerve is, and this is an example of what the sinuses look like too, because I don't think a lot of people know that it's not just the nose, but there's also paranasal sinuses that are connected to the nose and the turbinates. And it's kind of like Halloween, I know, early Halloween. But if you can see here, this is someone's face, right side of the face, left side of the face. And between our nose and the cribriform plate, we have these aerated caverns. It's almost like you're going spelunking in these caverns that are behind the forehead, between the eyes, behind the cheeks. And that's where some of the diseases occur that we see very commonly. We know that patients who have lost their sense of smell have significant impairment. And it's interesting, one of the other talks mentioned about how we smell in there's interaction with different senses. And when patients lose their sense of smell, they often describe it sometimes as like how we smell and color. So they say like, well, it's like watching, or my world is now black and white, or my world is blank, or it's like playing the piano and there's some keys missing, so even that auditory kind of association. But there's significant depression, anxiety. Even patients who lose their sense of smell, have smell deficits, die on average earlier than patients who have normal sense of smell. There's loss of smell can be a harbinger of Parkinson's disease or Alzheimer's disease. So there's a lot of interactions between smell and memory and cognition, super important. And it's really interesting, as medical students, we learn that this is the first sense, the olfactory nerve is the first cranial nerve, but there's still so little known about it compared to some of the other neurons, other nerves. And So it's fascinating, the wide range of ability, too. We talk about receptors as well, as Dr. Cole mentioned, but within even those receptors, there's people that have this remarkable talent of being able to, like super smellers and super tasters, right? So, for example, like Thomas Keller, who is a famed chef, or Thierry Wasser, who is considered the nose for the House of Guerlain in Paris, and sommelier, this famous sommelier, Sabrina Manolio. And then COVID happened, and then I met other people actually who we were wanting to study and also collaborate with. Michel Kripa, I read this article in the New York Times, who was a super taster. I didn't even know these people existed in the world, but he's a gastronomic expert. He can differentiate like different variations of nectarine versus apricot and things like that. And he completely lost all of that ability with COVID, unfortunately. And now he's developing things like it's called a sensory box. But here, just to give you a sense of what it is, it's olfactory training where we have different scents. And you can see on the left lower hand, there's jars. This is from a UK company called Absent. But there's 4 different scents: lemon, rose, eucalyptus, and clove that are considered the 4 important different categories of scents that Thomas Hummel in Germany actually did. He's an olfactory researcher, has developed. So we're using a lot of these kinds of techniques to help patients with their sense of smell and to hopefully bring back that sense of smell, because we know that with COVID, up to maybe 1.5 million people now cannot smell. And that's in addition to about the 13 million adults now in the US that already had olfactory dysfunction. And they are unfortunately a younger cohort, so that means a longer burden of disease. This is a great article from one of my colleagues that talks about the impact, and we'll hear from one of our colleagues too about the impact of not being able to smell. But one of the quotes, I think, on the left-hand side about the world is very blank or shades of decay. I feel alien from myself, like a part of me is missing. It's detached from normality and lonely in my body. It's so hard to explain. And then the bottom right-hand quote is so interesting because it's true, I think, and I think that's where conferences like this are so important. It feels like it'll be years before medical knowledge catches up to what we are experiencing, and that is a strange place to be. Because we, as physicians, we see these patients and we find that, gosh, wouldn't it be great if there was like an olfactory medication that we could spray, or like a implant or something like that could bring back patients' sense of smell and help with and patients' flavor. So, I'll go ahead and keep skipping. So current methods of assessing smell, Dr. Benkovo, who's my colleague at Brigham Women's Hospital, very rudimentary. This is how we test for patients' olfactory dysfunction. As we know, with hearing tests, we have audiograms, right? For vision tests, we have some fancy visual assessments, but this is how we currently measure smell. These scratch and sniff tests like this. And can you imagine, you have to scratch that brown box and then choose between the 4 odorants. And as we heard, pumpkin pie is probably a really complex combination of different chemicals and odorants that stimulate different receptors. But this is what we have as of now. And then on the left-hand side, you can see these, they look like markers. And you can see a patient undergoing testing on the far right side. And it takes a lot of time and effort. And so we thought, can we find a better way to measure and create an objective measure? Like, can we create an audiogram? Can we create an olfactogram? Because that doesn't exist. And we don't know, we can't gauge how severe a patient is and what type of dysfunction it is. How can we best treat and diagnose and manage the patient and then see if interventions work, right? So we did the study at University of Pittsburgh Medical Center where we created a little olfactometer or olfactory stimulator that delivers scents like amyl acetate and phenyl ethyl alcohol, which are fancy ways of saying rose and banana. And there's this really that looks like an osmonaut going up into olfactory space. I don't know, but it's called a MEG, a magnetic encephalography. So it combines EEG with MRI, so you have both the temporal and spatial capability to really look at how the brain processes scent. And I think, even though we talk about receptors, I think also it's how the brain processes the electrical signals that's also very important. And so we did this study where you can see the rows and little bananas, and we had a computer program paradigm where we would deliver these scents in second intervals and then measure in the MEG what the brain was doing. And we found some really interesting findings, not in the olfactory cortex, but orbitofrontal cortex, et cetera. And we're still kind of trying to do more of these types of studies, because what happened was that once this study, we started doing the study, then COVID happened, and then we're like, well, we need to transition to more COVID-related smell loss studies, and we were really interested in how smell loss affects cognition too. So this is just a complex way of looking at the different cognitive studies that we did. Opposite is that scratch and sniff smell test that we had patients do who had actively infected, active infection, recovered, and patients who are healthy, and we found that there was significant impairment in processing speed in patients, which processing speed means that how you can process information or make sense of information and then respond to it. So that seemed to be significantly decreased in patients who had COVID-related smell loss, which was interesting to us. And Dr. Benkova will talk more about some of her cool studies she's doing, because it's so important to continue to make progress in this area. And as surgeons, we do surgery. Obviously, we like to operate, but hopefully in the future we'll be better, have more advanced therapeutics for this. And so the next steps I think that are really important from at least the medical side and the needs, that we need a high fidelity measurement of olfaction. Quick, cheap, easily accessible. We don't have that now. We need to understand what happens with olfactory loss and what happens with recovery. What is parosmia? Because parosmia is super common right now. It's like when things like coffee taste like sewage, or I have patients that say that their partner smells like garbage, and then they want to kick them out of the house. I'm like, oh no, don't do that. We need to work together. Maybe olfactory training might help. And then finally, develop therapeutics or implants or something that can restore that sense of smell. I'm going to skip ahead. And so I'd like to thank everyone. It really takes a team. This is my team from Pittsburgh. And my email address, if anyone would like to contact me. I appreciate your attention. Thank you.
Thank you so much.
Thank you.
So this one doesn't work. One that works, maybe. Yes, correct. So a great big thank you to Dr. Lee. These mics don't work. Hello. A great big thank you to you for a wonderful presentation. And I think that we will have a panel at the end of this with also Tara Scudder, who is here, and she's a proper anosmic. I would love for you to put her into your device where you do the MEG, the magnetic encephalography, as well as the EEG, and see was she born anosmic. I think this is a moment. But I don't.
Yes, I did.
She's coming.
Tara.
She's coming.
Yes,
She's going to be here next.
Yes.
You did meet her already,
Yes.
so that's wonderful. I did have this question. So, do you have a sense of why we haven't developed things like EEG up until now? Why did we have to wait for it? Because all the other senses we've done this for.
I know. So
Why?
yes, so smell is considered the Cinderella of the senses in the terminologies, because like vision, for example, or auditory perception, they've been perhaps even just the perception of that smell is not so important. And some patients don't even realize that they have impairment in smell until it's completely gone. It's kind of like an invisible sense. People, if you have that impairment, a lot of patients feel invisible. And so now with COVID and so many more people impacted, I think there's more awareness of how important it is, and obviously the parosmia or the distortion. But that's a great question. I think otolaryngology or rhinology, there are not many doctors in this field. We are very, very small subspecialty of surgery, and as surgeons, we're very busy removing things and thinking about how to best approach tumors of the sinuses or take out brain tumors through the nose or something like that. But the research has lagged, and there are many new therapeutics and things like that, but I think we do need more. And I was just at a NIH grand rounds this morning. Deborah Tucci, she's the head of the National Institutes of Deafness and Communication. She said, wow, we really do need more attention to smell, and we need to encourage physician scientists. That's so important.
Yeah. Here. Okay. There's a question from the audience here.
Thank you, Doctor. Tomorrow we have the moot court competition, which is law-related stuff, but the question, and I sort of drafted the problem, but one of the questions is, can we refresh the memory of a witness? And this is something you touched upon. Can we revive a memory through a scent?
Yeah.
And then the question is, how accurate can that revival be? Or is there any studies or anything like that that can kind of show the validity of something like that?
Right. Well, that's almost like a philosophical question too, right? Like a memory. What is memory? What is reality? And what
we
is
love
memory
those
really
things.
like that perception of what reality was? But that's, I think, super interesting because we know that as we age, those memories and our ability to create those memories and hold on to them, our cognitive abilities do deteriorate, and smell, for some reason, is one of the first indicators that goes. So my thinking also was, can we use olfactory stimulation then to then increase the opposite? Like you said, like increase our cognitive ability or increasing our processing speed or increase our memories. So I think maybe in the future we might be able to do that, like have a bionic ability to do it or revive or restore memories. But memory and smell are closely tied, yes.
Hi, I was curious how you choose your model odors, like particularly with rose, it's one of the most common ones for people not to be able to smell.
Yes.
So I was curious like why you chose those ones specifically.
Yeah. Actually, we went there because we have those chemical structures, but also Thomas Hummel, who's informed a lot of our olfactory research, there's different categories, like how in taste there's like sour and sweet and things like that. In smell too, there's like floral versus citrus versus resinous, so that's why rose is in the floral category, and like lemon would be in the citrus category. But those categories are important, stimulating different parts. And maybe Dr. Kolb could also explain that a little bit better. I'm definitely not the expert in the chemical structures, but we do at least know those chemical structures and then can reliably test it and then dilute it to like a more scientific level, and then it can then be dissolved in different kind of like mineral oil or whatever, and then delivered in a more reliable way.
Okay, cool. Thank you.
Yeah, thanks.
So you talked about a consequence of people with COVID-related loss of smell being processing speed, and I was wondering what more about like what you attribute that to, because having hearing loss, that is actually one of the biggest side effects, and it has a lot of ricocheting effects, such as access to my education. So, yeah, I want to hear more of your thoughts on that.
Yeah. I think with smell, similar to hearing and vision, we are bringing in stimuli from the outside world, and then we're able to hopefully enrich our experience of our world too, and how we interpret data. And I think when we have impairment of those inputs, it can be very disruptive to how we can interpret the data and then respond. So this is a very theoretical thing. I don't have the data to prove that, but I think, and also it's hard to differentiate sometimes from the COVID infection and how it globally impacts brain function. I mean, it's interesting. It shows that there's, the decrease in the size of the olfactory bulb and the neurons, and so there may be global cognitive issues that are manifested in that too. But that would be my explanation.
Yeah, I'm also wondering, like other effects of COVID, such as like masking, which affect smell and hearing loss, if there's consequences related to that as well. I don't know, that'd be interesting.
You mean masking? Oh, okay, yeah, sure.
It's a valid question.
Yeah.
Because it does lower the amount of signal that's relevant, so who knows what that does to the brain. But
Yeah. But even with, the N95 mask that we wear at work, you can still smell the odorants and,
Right.
fortunately or unfortunately, I don't know. So the smells, yeah.
Okay, thank you so very much, Dr. Lee, and for the